Recording. So thank you very much to Tiffany and Emily, who are going to present on the dignity of risk and duty of care. This was something that was quite new to me until earlier on this year. Didn't know a lot about it, still don't know enough about it. So I'm very, very grateful for you both presenting on this and relating it to falls as well. So thank you very much. Tiffany, do you want to take it away?
Sure will. Thank you so much, Sue. And thanks everyone for taking the time to attend this Falls Lecture Series presentation this afternoon on dignity of risk and duty of care. I would like to begin by acknowledging the traditional owners of the unceded Aboriginal lands that we live, work and gather on, and their ongoing connection to country and community. I would like to pay my respects to their elders past, present, and extend that respect to any Aboriginal or Torres Strait Islander people joining us today. It is an honour for me to be presenting to you from Wadandi Budja this afternoon. Joining me today is my colleague Emily Wood, who is our clinical nurse specialist in the Aged Care Directorate for WA Country Health Service. She holds our Falls portfolio and many other clinical portfolios, and I'm the acting director of aged care for WACS at the moment. Emily and I both have a really extensive experience in residential care, but we have tried to make sure that the flavour of today's presentation is not focused on residential care, because obviously the concepts of duty of care and dignity of risk and falls happen in all sorts of healthcare environments. So just a quick overview of our presentation today. There's a lot to cover in these topics. We will try and make reference to falls as much as possible for our target audience, but as I said, not specifically for older adults, although many of our examples do come from an older adult space because of the high incidence of falls in that cohort. So we'll talk about the concept of dignity of risk itself, the ethical principles that underpin that, how surrogate decision-making can be used to guide risk assessment when a person doesn't have capacity to understand or to accept risk, and we'll use some case studies that will illustrate the balance between dignity of risk and duty of care, and have a discussion around the impact and decision-making around restrictive practices as falls prevention. We have left some time for questions at the end, but please jump in if you have any questions or comments that you'd like to make during the presentation. I can see most people down the side of the screen, so maybe a Teams hand, or perhaps if you've got your hand up and I miss you, Emily, also please feel free to direct us to that person's question. So dignity of risk is essentially the concept that people who have decision-making capacity have the right to make their own decisions and live the life they choose, even when that decision involves elements of risk. So as health professionals, we need to make sure that people, our patients, clients, residents, all their surrogate decision makers understand the risk and consequences of their decisions, and that we respect their rights and dignity by supporting them to safely manage those risks. So we can see that the person in the slide is clearly very safe, but are we upholding their dignity? I think that's a little bit questionable. So quick flashback to those of us who are clinicians, to our medical ethics training and the 4 major principles of ethics in healthcare. We're taught that autonomy is paramount. That holds true for us as individuals. We almost demand that our rights and choices are respected, even when we're making choices that others might not agree are in our best interests. So we do need to make sure that we respect and acknowledge people's right to make choices that involve risk, but we also need to prevent harm. So the challenge for us in healthcare is that tension between the principles of autonomy, a person's right to make decisions for themselves, and our obligation to protect people from harm and ensure that their well-being is protected, which is the principle of beneficence. I feel that there is a changing culture in healthcare from being very risk averse to more of a human rights approach. It is happening slowly. It's very well enshrined overseas in health systems. It is in the legislation for aged care and NDIS, but it is more difficult to mandate or address that tension in acute settings. So what about duty of care? So our desire and our need to prevent harm dovetails with the concept of duty of care. So that's by duty of care, I mean our common law responsibility to take reasonable care that ensures our actions or our inactions don't cause harm to others. And I will pop in a caveat here, nothing that we say today is legal advice. So we do know that duty of care, the doctrine of necessity are legal terms that exist We use them as defence against negligence and in tort law, but this is not the focus of our discussion because it's absolutely not our area of expertise. We do have a duty of care to those in our healthcare settings, especially when we're looking after vulnerable individuals, for example, older adults. The risk of falls and serious complications does increase with age. As people get older, they generally experience increased frailty, and that does mean that well-meaning family, friends and staff of healthcare feel an increased need to protect more vulnerable people from harm. In unfamiliar environments such as hospitals, we know that there is an increased risk of falls for people who have mobility issues, physical or intellectual disabilities or cognitive impairment, partly because it is an unfamiliar environment, disrupted sleep, risk of delirium, the comorbidities that have brought them to hospital in the first place. And we do know that staff interventions when it comes to duty of care can be overly cautious because we do rightly feel an obligation to protect patients and clients and residents from harm. So we often have involved increased supervision or perhaps the use of restrictive practices in order to prevent harm from falls and to fulfil that duty of care. And we just need to be careful that a well-meaning intention can easily swing too far in the other direction and be perceived as paternalism, where we think that because we are the healthcare professionals, we know better than somebody who perhaps has the capacity and the ability to make those decisions themselves. So important to not be paternalistic. So it is a balancing act, and my photo there is from Cirque du Soleil, just because I went on the weekend and it was awesome. If it's still on, I'd encourage you all to go. That fellow certainly has got the balancing act well and truly down pat there. So when we talk about care and risk, we can see them as opposite ends of the spectrum. The dominant ideology puts them at opposite ends. We provide increased interventions, we remove potential risks, but we also then run the risk of compromising a person's level of independence and autonomy. Less intervention is more risk, but more independence for the person. So duty of care does mean we need systems in place to limit risks, but not at the detriment of a person's right to decision making. So instead of focusing on how risk can be avoided altogether, we should be prioritising what can we do and how can we best support someone and design a strategy with them to let them safely do what they want within the parameters of our system. So, for example, you may have a physiotherapist that recommends a client needs hands-on assistance to safely ambulate. If you think about that, that essentially means that person can never go anywhere independently if we follow through on that strategy. So if that person declines to have that hands-on intervention, we can support their decision by implementing risk mitigation strategies. And as I'm sure you're all familiar with the falls risk assessment tools and strategies that are in our care and support plans in hospitals and residential facilities and community programs. So there is a fellow who has some really good YouTube videos, Dr. Stephen Rabinovich. He's a researcher who does a lot of work in falls in old adults. There is a link to this particular presentation on the slide that you're looking at, and we can provide it with the references after. But he talks to his audience about their most recent fall, or asks them to reflect on their most recent fall. So not necessarily old adults in the audience. You know, might be roller skating or perhaps some iffy dancing. And Em, maybe you would humour me and tell us about your most recent fall and we can go through this exercise.
Thanks, Tiff. I'd love to. So my most recent fall was actually only a couple of weeks ago when I was participating in our office Olympics when I decided to compete in the long jump competition. So that was outside on the oval.
So do you think that participating in the Office Olympics long jump would be considered unreasonable risk-taking or reckless?
Perhaps maybe after I fell over, I thought maybe, but no, I don't think that you would consider it really an unreasonable risk or reckless.
Do you think that a reasonable person, so just a bystander on the street, would they have tried to prevent or alter the way you performed that, what I'm sure was an amazing long jump, that led to your fall?
They quite possibly may have tried to alter the way that I performed it because it was quite wet and muddy that day. and I was wearing an old pair of Converse All-Stars that had no grip on them. So perhaps they might have suggested that I take my shoes and socks off, like my colleague had done, who ultimately won the heat.
So a bit of risk assessment and risk mitigation there potentially could have happened. But at the crux of dignity of risk, would you be okay with needing someone's approval to participate in the long jump?
No, I wouldn't. Definitely not. You know, I'm a 38-year-old woman. I like to think that I can make my own decisions. They may not always be the best decisions, but they are my decisions to make.
Thanks, Em, and I hope we haven't shamed you with your long jump fall in public. So thank you for sharing. I will hand over to you now to talk about supporting risk taking for people.
Thanks, Tiff. So supporting dignity of risk involves a degree of judgment. Supporting an inpatient to eat sandwiches when a speech pathologist has recommended a texture-modified diet is very different to supporting a request for a nursing home resident who wants to continue to cook traditional foods over an open fire, that's very different to supporting a young mother who is mobilising in an electric wheelchair who wants to walk their young children to school along a busy highway. Risk assessment and planning may involve other strategies or additional safety measures to ensure the person and others are supported to undertake the chosen activity in the safest way possible and acceptable to them. So there's a few standard questions that I guess you would consider in assessing the degree of risk and appropriate strategies. So does the choice involve anything illegal? So obviously we don't want to be supporting any illegal activity. Will it impact on the rights or safety of others? Is there an imminent risk of serious harm to that person or to anyone else? And do we have the skills, qualifications and resources to provide the support to that person? And if not, can we help the resident or the patient to access that support? And finally, does the person have capacity to make that choice? So what is capacity? It's the person's ability to make and communicate a decision. So it's important to consider a person's capacity to make decisions, as without capacity, you cannot assume risk. Where the person does not have capacity, determinations of ability to accept or take risks is made by their substitute decision maker. So presumption of capacity. So we must work on the presumption that every adult patient has capacity, except when it can be shown by a clinical assessment that they do not have the capacity to make a decision. So capacity is related to cognition, but poor cognition does not automatically define capacity. Capacity can change or can fluctuate. It's situation specific and it's decision specific. Making a risky or a wrong decision does not mean lack of capacity, and it's a spectrum. So when we are assessing capacity to make a decision, there's a few steps in the process that I will go through. So there's understanding. Do they understand the information about the choice that they're making? So, and are they able to state the relevant information? So when we're thinking about dignity of risk and making a decision that has an element of risk to it and that may potentially lead to a fall, we want to know, does the person understand that there's a risk of falls? And do they understand the consequences of a fall up to and including death, which we will touch on a little bit later in some case studies? Then appreciation. Do they recognise how the facts are relevant to themselves? And reasoning. Do they have the ability to compare the options and understand the consequences of the choice? And are they able to express what they want to do? Is it consistent? Is it consistent with previous similar decisions or their general way of life? And then freedom. Does the person or their decision maker have all the information needed to make that choice? And are they making the decision freely without being influenced or coerced? So next we have, we'll talk about this gentleman in this case study. So it's come from the recent issue of the Residential Aged Care Communique, which focus on geriatric trauma management and looks at an interesting case highlighting the poorer outcomes that can occur for older persons following trauma, and in this instance it's post-fall, and how the desired goals of care may influence decision making. So after a fall at home requiring hospitalisation, Mr. DC was admitted to a residential care facility. Despite fall strategies being implemented, Mr. DC had an unwitnessed fall in the bathroom, after which he was transferred to the acute care hospital. Imaging showed a left hemothorax and rib fractures, and a CT scan of his brain showed no abnormalities. A conservative approach was actioned, and during his 2-week inpatient stay, Mr. DC developed a delirium, followed by pneumonia, and he died. The cause of death was listed as complications arising from a fall, and the case was referred to the state coroner. Mr. DC was assessed on multiple occasions by the physio, who considered that his shortness of breath on exertion and poor balance limited his mobility. Recommendations to the care staff included reinforcing the use of non-slip socks and use of a call bell to ensure assistance when mobilising. Recommendations to the family included ensuring they provided him with good, well-fitting footwear and clothes. 2 months after moving into the aged care facility, sensor mats were installed in Mr. DC's room to alert staff if he was mobilising, and a podiatrist assessed and treated his feet. Other falls prevention strategies that were put in place for Mr. DC are listed on the slide there. The coronial nursing consultant considered Mr. DC was at high risk of falling as he wasn't compliant with seeking assistance when he wished to mobilise. His falls all appeared to have been unwitnessed, suggesting he attempted to mobilise or transfer independently, which made it really challenging for staff to keep him safe. The falls risk assessment was all up to date. So there was a couple of issues that the coroner had requested clarification on. So one, why, despite the multiple recommendations from the physiotherapist that Mr. DC required appropriate footwear and non-slip socks, was he dressed in neither when he fell? And the second was it became apparent that a kitchen staff member had witnessed Mr. DC mobilising independently, but it was unclear why the care staff were not notified of this fact. So the coroner's recommendation, it was interesting to note that the coroner's recommendation that falls prevention strategies should be implemented at all times, with no consideration given to resident choices, dignity of risk, or restrictive practices. So the well-known gerontologist and researcher, Dr. Kate Gregorovich, provided commentary on this case. She stresses that falls prevention strategies need to be co-created with consumers. It was noted that Mr. DC had not worn appropriate footwear or called for assistance at the time of the fall that led to his death, and that he was reported as being non-compliant with seeking assistance. While it's assumed that younger adults have a right to undertake risky activities, such as bungee jumping or drinking alcohol to excess, the same dignity is not always given to older adults. Falls prevention should be undertaken as a shared decision-making, where the person at risk of falling and the health professionals work together to develop a plan that is in keeping with the individual's goals and preferences. Dr. Kate says we could speculate that Mr. DC may have valued his independence and not wished to call for assistance mobilising, and he may have chosen not to wear the prescribed footwear. It does raise an ethical challenge for healthcare professionals in balancing duty of care, autonomy, and beneficence. But we mustn't lose sight of the fact that individuals or their substitute decision maker do have the right to take risks. The recommendation by the coroner that fall strategies should be implemented at all times, particularly preventing any independent mobility, risks excessive restrictive interventions in the name of duty of care. So I'll hand back over to you now, Tiff, for case study number 2.
Thanks, Emily. And this case study is a nice comparison with the previous case. It's actually the story of a gentleman that I cared for in a residential facility who had been admitted after multiple falls at home. So we could see there on the screen a little bit of his history. Some staff were suggesting that he could be best cared for in a princess chair or a tub chair, a sort of deep chair, to restrict his mobility as a falls prevention. And around the time of this, it was time for his initial care conference, so that happens quite soon after admission, and allows residents, surrogate decision makers and staff to come together to co-design a plan of care that meets an individual's needs and goals, as Emily's touched on. So the wife and daughter were present at the conference. I was the residential manager at the time, and there was also a graduate nurse present. And she had expressed concerns that given this gentleman's, one of his key issues was falls prevention and management, we knew there would have to be a conversation around dignity of risk. And because it was a relatively new inclusion in the Aged Care Act and standards, the graduate nurse didn't feel entirely comfortable to have that conversation with the family. So I had stepped in to provide her with some support. So we first acknowledged to the family that admission to care, hospital, residential, respite, doesn't guarantee that the person will not fall, but we do have resources and staff to support falls prevention and the ability to quickly respond and to implement strategies. We had to talk about informed consent to take risk, and that involves knowing all of the options, the consequences, and how they relate to the individual. A discussion that options for falls prevention do often involve restrictive practices such as the princess chair or the tub chair that staff had suggested to the family. But those restrictive practices bring their own ethical issues and sometimes physical risk. So we discussed consent for restrictive practices, the risk of physical deconditioning if someone is confined to a chair, and the distress that being confined to a chair could cause someone who's up to relatively recently led an active life, enjoyed walking when he was at home and had enjoyed walking through the facility and the gardens. So discussed the role of the surrogate decision maker and supported the wife to understand duty of care and dignity of risk, and how weighing up those two concepts is a really personal choice and is best made by the person who knows that individual best. So that we know that when we talk about surrogate decision makers, we're hoping that people have been selected who are making decisions in that person's best interest and knowing what they may have chosen, were they able to make that decision themselves. And we always stress to people that there's no right or wrong when it comes to acceptable risks and strategies. It's a very personal decision. Some people might prefer a higher level of interventions that reduce risk, while some prefer to accept a higher degree of risk that comes with less restrictions. So that's all about that person-centred care and co-designing those strategies with people. So if we refer back to the terminology of the decision-making that Emily spoke about in the previous slides, understanding and appreciation that as the surrogate decision maker, the gentleman's wife had to fully understand the options around the restrictive practice choice or the choice to ambulate without assistance, and to understand and reason through the consequences of that choice. So it's critical to informed consent that we ensure people are aware of all of the consequences of their options, and it can make dignity of risk conversations quite confronting, as it was for the graduate nurse in this scenario, to be talking to a family and explaining that the choice they make could actually lead to the death of their loved one. And it is important to be explicit. A serious fall could result in a bleed on the brain that could be fatal. Give the information to people in a language that they can understand, so that they really are making a choice based on a worst case scenario. These are not the times to use language around, well, they could have negative outcomes from a fall. It's really important that in order to make that choice, people explicitly understand those consequences. And when it comes to expressing a choice, can she express her husband's wishes? Is it consistent with his best interests? So after a really lengthy discussion, the wife and daughter were able to articulate that Dad had always been fit and active. He liked long, rambling walks, and they felt that being confined to a chair or only able to be taken for a walk with staff would be more distressing for him and decrease his quality of life. They were able to express that as a choice that was consistent with his values and felt that it was the decision that he would make if he had the capacity to do so. And I think importantly, they were also able to weigh up that proportionate risk. You know that by the time someone hits residential care, their life expectancy is already limited. And I do recall them saying he could live for 2 years unhappy and confined to a chair, probably trying to climb out, or a much shorter time with greater quality, free to roam the facility, and understanding that a risk of serious injury or death as a complication of a fall could well be a result of that decision. It was a really lovely conversation to be a part of, and the family were comfortable with the decision. It was very carefully documented to demonstrate that that was an informed choice and acceptance of dignity of risk. And I think it was a really nice example that evidenced person-centred, co-designed care, and support staff who may otherwise be considered in breach or feel that they would be at risk of breaching a duty of care if they didn't supervise this gentleman's every step. And just as a footnote, he did die after complications from a fall some 8 or 9 months after his admission, and the family was still comfortable with the decision that they'd made, because the other side for them would have been that Dad would have been confined to a chair for the last 8 or 9 months, and they knew that that's not what he would have wanted. And so why do we so often choose restrictive practices over dignity of risk? And I think it goes back to beneficence. We assume good intentions. We don't want the people in our care to come to harm. But maybe we don't have adequate knowledge about the implications or the harm of the restrictive practices themselves. We might fail to consider that that intervention has its own risks. We no longer use lap belts or zipper beds in residential care because of the risks they pose. Who else remembers posy jackets, or seeing residents or patients literally walking with a chair strapped to their back like a Sherpa because the posy jacket that has been designed to keep them in the chair has kept them in the chair, but they've just taken the chair with them when they have ambulated independently. There's a lot of psychological harm and distress with being restrained or confined to an area. We've all seen people climbing over bed rails, which is as much of a falls risk as getting out of bed and falling in the first place. Sometimes we're looking at the expectations and beliefs of other people, especially when it comes to duty of care. We might feel that we must keep people safe at all costs in a healthcare environment. A family may say, well, I don't expect my loved one to go into care or be in a hospital and fall where they're surrounded by staff and people. Sometimes we can be a bit paternalistic. I know what's best for you because I'm the health professional. And I think it's fair to say that not all of our reasons for use of restrictive practices are necessarily as positive intent. It is possible sometimes that in a busy ward environment, let's be frank, it's simply easier to have a person restrained or in a recliner chair, or perhaps with some kind of chemical sedation, than it is to manage wandering or intrusive behaviours. And while this is specifically against aged care and NDIS legislation in residential environments, hospital wards are not regulated in the same way. And so acceptance of that dignity of risk in relation to falls management, in my experience, is not as well evolved as it is in the aged and disability sectors. But despite the differing legislation, the ethical principles and human rights approach of dignity of risk are the same no matter what care environment you're in. This is an example of a form we use within WACS, and I'll throw to Emily just to have a bit of a talk through that.
Thanks, Tiffany. So this is our My Choices Dignity of Risk form. So we use it to document informed choice around activities that involve a degree of risk. And this can be for something as simple as not wanting to be checked on every 2 hours at night, to texture modified diets and fluids, and ambulating without assistance. So the form guides the clinician and the resident through a shared decision-making process, and it prompts them to be really specific about the resident's wishes and why it's important to them. So it guides them to consider the safety concerns and the risks and possible consequences of the activity and the potential benefits of undertaking the activity. It also guides them to explore alternative options, if any, that might be acceptable to the resident. So it enables them to develop a plan for how the resident will undertake the activity and how the staff and or family and friends can support them to do so. So I think that's it for our presentation. Is that right, Tiff? So if anyone has any questions, we are happy to take them.
Thank you. That was absolutely brilliant. What a wonderful presentation. Thank you very much. I'm just going to stop the recording before we take the questions. Just hold on a moment, everybody.